There's still a gap in our knowledge of where the bubble forms. If you take blood and decompress it, compress it, saturate it with gas and decompress it, it's hard to make blood bubble. But if you have a nidus in there, for example, the tissue, you can get the bubbles. So there's some kind of a nidus event that you need. It's not just enough to have supersaturation. You have to perturb the system in some way. So most of us think that the bubble actually forms somewhere at the tissue-blood interface, so maybe in the capillary. And once there, or if it's near the capillary, the bubble is very powerful erosive force, and it will break right through the capillary. And that's why you see micro hemorrhages sometimes in tissues after decompression sickness. So the bubbles break into the venous system, the low pressure system, and then they travel through the venous circulation, through the right heart, to the lung. And the lung is a very effective blood filter. The lung will stop anything that's more than about the size of a red blood cell, about 7 microns or 8 microns in diameter. It's a very good filter. And that's why we don't constantly have trouble with particulates that get in our venous system going through the lung and causing damage to our hearts or brain, because the lung's a good filter. And it's a very good bubble trap. And so those small bubbles that do form, eventually that gas diffuses across the lung and out to the environment, and you don't have any trouble. So most of those small bubbles, even if there are a fair number of them, don't cause any kind of pulmonary problem and don't ever get to the arterial side where they can obstruct blood flow. Now there are some exceptions to that, and that is when the pressure goes up in the pulmonary circulation. If you have a high driving pressure behind the bubble, those bubbles might squeeze across the pulmonary capillaries. We already talked about the PFO. That's another risk factor. If you raise the pressure in the pulmonary circuit, then the blood can go from right side of the circulation to the left, and if it contains bubbles, those bubbles get carried along with the blood flow. The third issue is pulmonary abnormalities, such as arterial venous malformations, where you have an unusually large connection between the venous side of the pulmonary artery, or the venous circulation would be the pulmonary artery side, and the systemic or arterial side. If those connections are bigger than the 7 or 8 microns that I mentioned, let's say you have a vessel that is 10 or 15 microns, then larger vessels, larger bubbles can pass through those channels and can cause symptoms on the arterial side of the circulation.
But of course, even small amounts of bubbles in the arteries isn't necessarily bad. In people who, in clinical medicine, where one is looking for a patent foramen vale or an atrial septal defect, the diagnostic test of choice is to actually inject bubbles into a vein. And in people with PFOs or intrapulmonary shunts, some bubbles do get into the arterial circulation and don't seem to cause any problems. So everything is a matter of degree. A lot is bad, a lot causes problems, whether it be on the venous side, hurting the pulmonary capillaries, or on the arterial side, having broken through.
What the bubbles do, and this is an important point, it's pretty clear that if you have vascular bubbles and you have too many of them, they can damage the endothelial cells, the lining of the circulation, and as a result, that can cause stoppage after the bubbles are gone. So what you're doing here is passing the bubbles through, and then you're seeing they've caused some damage that after they're gone causes you the symptoms you get, and that's really, I mean, it's like if you hit your knee with a hammer, you're going to have a bruise that takes a while to heal up, and the more bubbles you have, the more that's likely to happen.
The bubble-blood interfaces tend to form clot. You get platelets, which are the initiating factors for clot formation. They're little tiny cells in the blood lining up on the surface of bubbles, and then you get fibrin formation. So the body does its best to try and isolate a bubble and make it into something solid. But bubbles do other things as well. They, when they're in blood, they tend to destroy the lining. The lining of blood vessels is a very smooth surface. It's generated by endothelial cells. It's called the endotheliums, the inner carpet. And bubbles tend to destroy the endothelium. And in so doing, that does at least a couple of things. One is that it makes blood vessels leaky, so that fluid can leak out. But it also destroys certain properties of blood vessels, that is, the signaling pathways by which they decide whether they're going to constrict or dilate. So bubbles do a lot of things. Of course, they can also cause direct mechanical damage. If you have a bubble within a neuron or near a neuron, it can cause impingement upon the blood supply to that neuron, or it could cause mechanical stretching of the neuron so that it doesn't work anymore. And we presume that's how it works in the spinal cord and brain.
We think within the spinal cord that there's probably bubbles called autochthonous, which is a fancy word for something that stays put. That might do damage just by growing in one place and stretching things. But we have no way of looking at these things in real time, and all we can do again is conjecture by looking at spinal cords, again, of animals that have been severely bent. And we do see gas phases within the spinal cord tissue.
And one of the areas which is interesting is that when you get these injuries, especially with spinal cord, you do the first treatment, 50% recovery. Some of them, 2 or 3%, will not make a full recovery. When you look at therapy very often may come a little late, and the concept is, well, it doesn't work too well then, and what damage have you done? Well, if you've got damage to tissue, that's one thing. If you have also affected a vessel supplying blood to that specific area and damage that vessel, then you've got a small area which is going to be non-functional in that cord. Now, the randomness of it suggests to me that it depends where the bubble occurs in different parts of the cord. And should it come in a critical area, it's like a telephone cables, if you will, again, to make it understandable. And a couple of the cables in a specific area short out. They happen to be rather key ones. They happen to work your legs.
So you notice.
So you notice it. Other areas, it might take out something, and people say they got paresthesias, well, okay, paresthesia, right, it's a bit numb. But there are other systems can take over some of that if you give it time, and that's okay. That can self-repair, so to speak. The more critical parts don't seem to repair quite so well.
Bubbles are a foreign body, and so they can cause coagulation, they can cause damage to cells and adhesion of some of the circulating cellular elements, and so it's a stimulus. That's what it is. It's a stimulus, and either a biochemical stimulus or perhaps a physical stimulus too.
Are you comfortable with a sort of complement activation concept?
Well, complement is certainly activated by bubbles. Now, whether it has a role in decompression sickness, I think is less certain. And it was one of the problems, and this is the trouble with this darn field, is that it's so hard to make measurements, and the complement measurements seem only to be able to be made in one laboratory, and it couldn't be reproduced in other laboratories, and didn't have the same associations. So complement is sort of gone out the window as a
reliable marker, at least.
Yeah, I mean, not that it isn't involved, but it didn't pan out. I mean, that would have been great. I mean, just like when Doppler came along, hey, that's going to be the answer to the problem. If there are bubbles, you got bends. Well, it didn't work out that way. But it doesn't mean that it's useless, and it doesn't mean you can't learn things, and it doesn't mean it's not involved. But that's going to take some more studies, and who's going to fund those studies?
I don't know. The bubble correlations are a difficult one. I believe we are coming very close now to understanding certainly bubble theory. Either bubbles deep on the Haldane studies, or the Yount studies and the Wenke studies and so on, that deep stops are valuable, and in fact they reduce bubbles virtually to nil. The next thing is to see what we do with that, whether or not we are going to be able to put that into algorithms. I think we are. I think the computer manufacturers, as I understand it, are now starting to put them in.
Yeah,
Because they recognize, well, I mean, their previous models were virtually untested, so based on the old concepts of US Navy tables or diffusion models and so on, that's okay, that's what we had, that's what we used. But now we've got something which is making us think very highly that we're going to beat the bubble, we're going to get that thing out of the way, so when you come to the surface there are no bubbles. So the next phase is to do that, and then you will find out if you get a drop in the instance of decompression illness. We get, what, 1,000 a year or so in the United States reported to Dan in terms of decompression illness. And 68 or 70% of those are neurological in origin. What I would expect to see if we started deep stops, that would drop off considerably. We would probably still get a few of the pain onlys because we're not addressing that quite. That's the slower tissues.
And those are probably underreported, wouldn't you imagine? Things like fatigue and pain, a little bit of pain, or people are not usually going to know.
No doubt about it.
Right.
No doubt about it. I mean, in fact, whenever we were doing work on this, people would say, in fact, when we started first publishing the details on the accidents, the comments were, well, but you're all underreported. There's more than that.